Okay, welcome everyone to the SPCR Masterclass on conducting a systematic review. I'm Tanimola Martins, and I'm going to be your host and one of the three presenters you're going to be meeting this afternoon. I'm going to introduce the remaining two presenters in a minute, but just a quick housekeeping. I think you've all done this, but would like everyone to put their microphone on mute except when you're speaking. And if you have any comments, any question, can you kindly use the raise hand feature in Teams? That'll be easier for us. Somebody is always monitoring the chat. If you have any comments you want to put in the chat as well. There are no fire drills in our building today. So if you hear any fire alarm, I think it might be your building. So do take the appropriate action and don't wait. We will provide the slides, and as you know, this session is currently being recorded. So you might want to take notes or not, but you get the slides anyway. There is a QR code on your screen. If you can scan that and just quickly do a quiz that we've set up for you, it's fairly straightforward. And if the QR code isn't working, you can just type in menti.com, menti.com, and the access code on the screen for a quick quiz. All right, quick introduction. So my name is Tanimola Martins. I am a researcher as well as a lecturer at the University of Exeter. I have a background in clinical rehabilitation and public health. My research focuses on ethnic inequalities in diagnosis of cancer, and most of my teaching is for master students on the Masters of Public Health program here at the University of Exeter. So far, I've published around 7 systematic reviews or contributed to those 7, and they include diagnostic accuracy reviews as well. So I have some experience in the conduct of a systematic review. I would now pass it on to Melissa and then Wawa to introduce themselves. Melissa.
Thank you, Danny. My name is Melissa, or Mel Barlow, and I'm a research assistant here at the University of Exeter. And I have led 3 systematic reviews and currently involved in another one. Also, Tanny, we've just had a note in the chat to say that the quiz is waiting for the presentation to start. If you could just start the Menti quiz, maybe, and I'll pass over to Wawa.
I'm Wawa. I'm also a research assistant with Mel's team, and I'm also a PhD student in University of Bristol. I've been leading 2 systematic reviews and participated several systematic reviews. Yeah, that's it from me.
You're on mute, Danny.
Sorry, thank you very much, Wawa. I can see the Menti is already working. It's live, so I can already see people commenting there. So what we aim to achieve today is to sort of give you a flavor of what you need to take into consideration when you're conducting a systematic review. We're going to go through all of the steps required to conduct a systematic review, as well as give you some ideas on how you can synthesize your review and then reporting the same. Throughout, we'll be giving some very, very easy to engage with type examples. This is not to make you an expert systematic reviewer, but maybe it will give you some reassurance that some of the things you're already doing are actually the right things to do. So overall, you're going to learn some things from us, and we want this to be as informal as it can be. So please feel free to chat, feel free to ask questions, and there is no such thing as a bad question. Okay. So we set up this quiz for you, and I can see that you already are engaging. I think the question here is, what are the differences between systematic review or conventional literature review or scoping review? And I can already see people saying methodological rigor to eliminate bias. Enough similar studies. So lots. There is no real pattern here so far, which is not a surprise. But I suppose when you're thinking of a systematic review, essentially what we want to do is to pull together the available evidence on a subject area. And we hope that by so doing, we might be able to set an agenda for further research. Say maybe we identify a gap in the literature, or we notice some differences, or we notice that, well, this area hasn't been explored, and we want to do a systematic review. Now, you can argue that a scoping review or a traditional literature review can do exactly the same thing, which is true. I think what distinguishes systematic review from the other type of studies, in the systematic review, we are hoping that you identify all available evidence on the subject area. And sometimes this is not possible because maybe at the time you're just doing your systematic review, somebody is just about publishing theirs or they are still writing up. And so by the time you finish, they publish and you miss those. What you can achieve in a systematic review is to get exhaustive amounts of study, in which case you know that having gone through this rigor, there would be no new evidence added. You know, you've reached what they call thematic saturation in qualitative type studies. So that differentiates systematic review from a literature review. The structure of you, as a few people have alluded to, matters. In systematic review, you have a rigid, relatively rigid structures you want to abide by. You know, you sort of develop a protocol before you even start your systematic review, and that protocol will guide every step of the way. It has to be reproducible. A systematic review will be conducted such that if Wawa decide maybe she's in China and she needs she did exactly what you said you've done, they should get exactly the same result. Validity. Some of you highlighted that in the mentee, that you want to check the internal as well as the external validity of the evidence. And this is actually a key factor in a systematic review that you actually don't tend to do in a literature review. In literature review or scoping review, you don't need to do what we call the risk of bias assessment, which is where you check the internal as well as the external validity of the evidence. Now, in a systematic review, you can do a meta-analysis when it's possible. And at some point, we'll let you know what are the conditions that you need to think about before considering a meta-analysis. But in a literature review and a scoping review, this is hardly a requirement, or is hardly considered, you know. So yeah, so some of the things you've listed here are exactly what I think distinguishes a systematic review from a literature review. It's systematic, you know, you collate evidence, it's transparent, it's excellent. You know, do we have any questions so far before I proceed? Whether in the chat or Elisa, do we have any question? Wawa, do you have any question in the chat? Fantastic. So everyone good? So now that we have a rough idea of what a systematic review entails, the question is, how do we start? Where do you start? You know, you have a topic, you're interested in cancer, you're interested in how cannabis can cure cancer. But where do you start from? A critical first step in a systematic review is the question. You need to, you know, a well-defined question. And usually in a systematic review, you want to develop your question such that it fits into what we call the PICO framework. That is the population, intervention, comparison, or outcome, and outcome. And there are different variants of this framework. It is important that your systematic review question is new. You don't want to repeat what has already been published there. So you want to do something new, and there are ways in which you can ensure that your systematic review is novel. You can achieve that by searching, and we're going to do a quick search shortly to see some of the, the preliminary searches you can conduct to ensure that what you're planning has not already been done. But you first need to derive or develop a systematic review question. Now, like I said, it is often better to use the PICO framework. It is possible that the way your topic is, you already have a clear, well-defined research aim and objectives. But when you use the PICO framework, it puts this into perspective. Remember, we want something that is reproducible. So the population, intervention, comparator, and outcome framework can be used. And you can have a number of variation of this. You can have population, exposure, comparator, and outcome, or you don't even have a comparator. So you can vary this whichever way works for you, depending on your question. And I've put a couple of examples here. So say we're interested in the role of cannabis in cancer management, and we're interested in prostate cancer, which we've used as an example here. So our population will be patients with prostate cancer. The intervention we're interested in, cannabis. And we may want to compare this intervention with another type of intervention, say surgery in this case. And our main outcome is cure or remission or all clear kind of results. You may want to tweak this differently and say, maybe your research interest is in how much cannabis is used by a specific group. Maybe you group in this based on deprivation or ethnicity or any other factor, as the case may be. And so in this case, you might have, again, you have the population being patient with prostate cancer, and you want to measure, or you want to look at evidence of cannabis use in a particular group A compared to a comparison group B. And again, your outcome can still be cure or any outcome you're interested in. Another possibility is actually you're not interested in comparing this treatment. You feel that cannabis is sufficient to cure cancer, so your interest is in patient with prostate cancer, which is the population. Cannabis is the intervention or the exposure variable, and then your main outcome is cure. So you can see here that there is no rigidity in terms of how you can vary your PICO in formulating your question. The important thing is to be clear how you've done so when you're reporting your systematic review. Okay, we're going to do a quick search, so we want to use, now that we've developed a possible research question, which is looking at cannabis use among cancer patients and see whether or not it leads to cure. So I'm going to quickly, if you can go on to PubMed on your computer, and if you can type, is everyone there? Just give me a thumbs up if you're on PubMed. Okay. Rama, yes, Karen. So I think a couple of people on PubMed already. Those are very quick. And so if you type in cancer, I hope you can see my screen. If you type in cancer and cannabis and click enter and see how many number of articles that come up. Hopefully, you have up to 2,000 articles coming up. Okay. So in case you're wondering 2,000, you can see there it says 1 of 20 pages, and on each page in my computer, I think I have about 20 or even much more than that. So you can clearly see here that a lot of study has been looking at cancer and cannabis. So if we're going to vary this and add our main outcome, which is cure, into the search, and we click enter, you can see it comes down to just about 20 or so articles which is explored cannabis in patients with cancer and is looking at the outcome of using cannabis in terms of curing cancer. So, but we want to know whether a systematic review has already been done on this so that we don't repeating what has already been done. There are two ways of doing this in PubMed. You can either click, if you look on the left side of your screen, you see quite a lot of options. If you click on the box that says systematic review, you can already see that there is just one systematic review that has been done, which is looking at cannabis and cancer. Has everybody got into that stage where I'm at now? You can, put in the chat if you've missed a step or you're not sure what I'm doing. Any question? Okay, Ahmed, is there a question?
No, sorry, that was a mistake. Yeah.
Okay, fantastic. So at this stage, it looks like somebody is already, beating us this game. They've done a systematic review looking at cannabis and cancer cure, but it doesn't mean that you won't proceed with your topic at this stage. What you can do is to look at this article very well and see whether what they've done is actually exactly what you plan to do, and if that's the case, you might choose to not do a systematic review at this point or actually decide to go a different way. But this is a simple way of finding out whether what you're trying to do is already been done. What you can also do is to go on the Prospero website. Now, the Prospero is a place where people will generally register their systematic review prior to the conduct of the same. So it's quite slow from my point of view. So I'm not going to take you through that, but we might do an exercise on Prospero. But Prospero is, if you type in crd.york or you just Google Prospero, it should bring up the website and you can look on there. And when you scroll down to look at a tab, an option that says search Prospero, you can type in your prospective title in there and search for it, and it will, come up with whatever is being registered. So they will, you will often find a protocol registered here, and you can look at this protocol and see whether or not it's exactly as what you're planning to do. I've put this down here as the search because I want to pull up a protocol that we published a few years ago, or a couple of years back. Okay, so that's how to ensure that your question is unique, it's not been done by anyone else, and put all of the elements in it to ensure that you're not just finding articles that are completely irrelevant to your work. That's a quick way of doing so using Prospero and PubMed. You can search any other database to check whether or not a systematic review has been done on your subject. Okay, now that you've developed a research question that you think is good enough, it's unique, it's novel, and it seems to be looking at exactly what you want to do, the next thing you want to do is to write a protocol. Remember, you want to write a protocol before you even commence doing your systematic review. And ideally, when you write a protocol, you can publish your protocol. As you can see here, we published this a few years ago, and it's been cited about 7 times actually. So you can publish your protocol in a journal, or you can register it on Prospero or several other places where you can register a systematic review protocol. I think there's a benefit in publishing your protocol. When you do that, other researchers will know that somebody is doing something on this work already, but also you can get two articles, from your systematic review. So it's always good. You're going to write the protocol anyway. You might as well just publish it. Okay. So what you need to publish a protocol, they're exactly the same thing that goes into your systematic review, and exactly what we're going to be going through today to include your background, making clear what the problem is and why the systematic review is necessary. You want to write out a well-defined research question or aim. You want to set out your search strategy, based on your PICO, which has to be well outlined in your protocol as well as in your paper when you do ready to publish. Your eligibility criteria has to be well outlined in your protocol as well. Your study selection, the risk of bias tool, and exactly what you're doing with the tool, because there are various tools as you find out. And you might need to modify, adapt them to your work. Your data extraction, exactly what you've been looking for in each of these articles that you found, and your data synthesis method, how you choose to summarize your findings from the articles, and eventually you want to tell us how you're going to disseminate your study, your findings afterwards. So these are the elements that you want to put in your protocol. When you're registering on Prospero, it's fairly straightforward. It doesn't have to be detailed, but obviously if you're publishing in an academic journal, you might have to be a little bit more detailed in your protocol. Okay, do we have any questions so far? Let's stop sharing. Let's look at the chats and see if any comments. How are we feeling? It looks like I've rushed this a little bit. Go on for it, Ha.
Hi there, Tanimola. Thanks very much for the introductory part of the lecture. I had one question. I'm in the middle of writing a protocol at the moment, and what I wasn't sure about was specifically the sort of data extraction. When I read I forgot what it's called now, the thing that tells you what to write in the protocol, the sort of summary guidance, Prisma, I forgot exactly what it is. That thing, it said about having a sort of data extraction manual, and I just wondered about how useful is that, because I've got a rough idea of what data I want to extract, like how big the study is, how many participants, what the results were, etc., etc. But how much value is there in having a sort of dedicated manual for the data extraction?
Okay, I'm not entirely sure what you mean by manual, but what you will normally do is to have a template. And we'll get to data extraction at some point. It's because you're far ahead in what you're doing. So what you want to develop a template, either using a spreadsheet or you derive a table, pilot a few articles from your search, to see what is coming up in all of the articles you found. And that will give you a flavor of some of the things you need to include in your data extraction. So essentially what you want to be saying in that protocol is, I'm going to develop a spreadsheet, and I'm going to use a few articles to test, and determine what data I'll be looking for. Obviously, you've stated out your outcome, which has to be related to what you're looking at. So it's just, getting the language right in your protocol. I hope that makes sense. Or Melissa, do you have something to add to that?
No, you've said everything I would have thought to say. That was great.
Good. Thanks for the question, Tara. Do we have any other question, or we want to go for like a 3-minute break? I can see a few hands up.
Hi, it's me.
Oh, thank you.
Yeah. So just a couple of questions that you mentioned about the Prospero. So I'm not very familiar with this thing. Can we register it on free, right? So it's a free platform where we can register.
Absolutely. We're going to put the Prospero link in the charts, just in case you want to have a look later on. And it's free to publish on Prospero. For some journal, if you target the open access ones, you should be able to publish fairly cheaper on those, but some of them will charge is it called publication process fee? I can't, APC is called. I can't
Yeah,
remember
yes,
this.
yes.
Article processing charge cost or something, which is usually not too great, but yeah.
And the
Okay.
second thing might be a silly question, just to know. I'm not familiar with the systematic review protocol. So according to your statement, is that something that search strategy, you're mentioning about the search strategy before doing something, right?
So yes, your protocol is like a statement saying this is what I'm going to do.
And can you publish this in a journal?
Exactly, you can.
Okay, oh, it's interesting. Thank you.
Yeah, you can, and you should if you can, if you have, the capacity to do so.
Thank you so much.
We'll take half this question and we'll go for 5 minutes break. Is that okay, everyone? Good. Go on, Abdi. You're on mute.
Hi, sorry. Just about the PICO, where you gave the example about prostate cancer and cannabis, you were looking at an intervention, a problem, an intervention, and a cure. If, say, I'm looking at something, I'm not looking at doing a review for an intervention, say I'm looking at barriers, how would I do that if I don't have I don't have something, I'm just looking at, active barriers for a certain community to receive, kind of care. How would I change PICO for that?
Excellent question. And this is exactly what I'm doing. You know that your population is cancer or diabetes or whatever disease it is. You want this patient with this disease. Now, usually when we're looking at barriers, sometimes we want to compare certain group with another group.
Mm-hmm.
So say we want to look at whites compared to non-white group.
Yeah.
Your exposure variable is usually that group you assume that will not get the best service. So in the UK, for instance, the healthcare system is designed in line with the majority ethnic group, which will usually be the white majority group.
Mm-hmm.
So you have population, cancer or diabetes, whatever the disease is. You then have your exposure group, which will be the ethnic minority group.
Okay.
Okay, and then you have your comparison group, which is that group that you think they get the best service or they will have less barriers, But you can flip it around to have your exposure ethnic group to be the non-white or to be the white group and the ethnic minority to be the comparison group. But actually, the group you're interested in as the exposure group is the ethnic minority group.
I see. And for example, in that example, the population would be people with, say, I'm looking at mental health. That would be my population.
Yes, mental health would be what you're searching for there.
Okay.
And then you have your exposure, your comparison, and your outcome will then be barriers.
Okay.
So after the break, we'll talk about how you deal with each of these terms. 5 minutes break. Can everybody be back here at 28 plus 5? At 1:35. Is that okay? Good. See you at 1:35. Okay, can you hear me, Marilyn?
Yep.
Fantastic. So yeah, we had a tiny bit of IT, but I think we are good to carry on. I'm going to share my screen again. Okay, can you still see my screen? Okay, thank you. So you've done all the hard work. You've you know your systematic review has been done, and you have the question all sorted out and you want to carry on. I think the next step, you've written your protocol, published it. The next step is to start to conduct your search. And I'm going to pass it on to Melissa for her to take us through this stage or this aspect of your systematic review. Melissa, sorry.
Hello, everybody. Our IT issues mean that we're now currently sharing Tanny's desk, so I'm not as used to this desk, so it might be a little bit clunky. But I'm going to talk through the search strategy, and I think that the search strategy is perhaps the most important step for your systematic review. It really sets apart a systematic review from a standard literature review because this is very strategic, and your whole aim of your search is to identify every single study that has ever been written on your research question, while also trying to exclude as many studies as possible that aren't relevant. So it's an incredibly important step. It's worth pointing out as well that because it is so important, you can get tailored help from your university. And I've listed the SPCR universities here. Don't worry about writing these links down. We'll get all of this sent to you, but you will probably have an information specialist team or an evidence synthesis team, and they can give you tailored one-to-one help on your search strategy. I know at Exeter, they're absolutely fantastic, so I assume they are at all of the universities as well. And also the NIHR have a Southwest searching and review clinic that happens once every 2 months, I think. So if you are in the Southwest, you can just book in a free searching and review clinic with them as well. Information specialist team, yeah. So step one of your search strategy is to first of all think about the bibliographic databases that you plan to search. So the one that everybody knows of most is PubMed. PubMed is actually included within Medline, so you don't need to search PubMed separately. If you're doing primary care research, I would definitely recommend including Embase and Medline. But then depending on your research question, you may wish to include some of these other databases as well. So just have some research of this by yourself and see if any of these databases may contain studies of interest to your research question. And make sure you include the dates that you've searched each of these databases. When you do a systematic review, you'll do your search, you'll spend a year or however long doing the rest of your systematic review. You'll then need to do another search right at the end to make sure that you haven't missed any other studies that have been published in that time frame. So make sure that you do write down the dates, so then when you go back to search later on, you can only search for that gap in time. So the second step is to generate and state keywords for your search. So our hypothetical research question for our systematic review is, can cannabis cure cancer? So we've got 3 main keywords, which is cancer, cannabis, and cure, but different studies might use different words to describe these terms. So cancer could be written as tumor, malignancy, carcinoma, or neoplasm, and cannabis could be cannabinoids, cannabis sativa, marijuana, and then cure could be relapse-free, survival, remission. There's loads of words. So you need to think of how all of the keywords could be included in any of the studies that you might want to return. You will also want to think about mesh terms. So mesh terms are medical subject headings, and these are used for indexing articles in databases, and they'll return any paper that have been indexed with the mesh term of interest. So you can find relevant mesh terms here. I'll send a link in the chat shortly. But for an example, the mesh term for cancer isn't cancer, it's actually neoplasms. So it's not always as straightforward as what you think. So make sure you go here, put in your keywords and find out what relevant mesh terms you have. And I'll show you how to include mesh terms in your search in a moment. Step 3, you want to consider Boolean operators and proximity searching. So Tanny's gone over this a little bit before, so he's mentioned the and Boolean operator, but there is also or and not. So these are pretty self-explanatory. So if you want to search for cannabis or any of the synonyms for cannabis, such as marijuana, you can search cannabis or marijuana, and that will return all studies that mention either cannabis or marijuana. And then you can use the word and. So for example, cancer and cannabis, and that will only include studies that mention both of those terms. So any studies that talk about cancer but have no mention of cannabis won't be returned. And this one's a really useful one for narrowing down the number of hits that you get at the end of your search. And you can also use not. I've never used not because it makes me feel a little bit anxious. You can search for cancer, not COPD, for example, if COPD was a big confounder. I'm a bit worried about using not because sometimes a study can be talking about cancer and may say that they're adjusting or controlling for COPD, but by using the word not, you won't have returned that study. So I think it can be useful, but just be very careful when you are using not. And you can also use proximity searching. So if you want to search for 2 words, but you want them to appear very closely together, you can use ADJ and then choose a number. In this example, I've used 3. So this will only return studies that talk about cancer, but within 3 words of cannabis. And an example of when I've used this in a search is I was looking at ethnic differences in a variety of blood tests. And I wanted to look at different ethnic groups, so white groups and black groups. But if I just search for white, that would return white blood cells, white coat syndrome, so many different things. It's totally irrelevant to ethnicity. So I used white ADJ3, black or Asian or mixed, and so on and so forth. So that one can be a really useful one as well. And I'm just going to give you an example of what a search will look like. And this is using Embase or Medline. So these might be slightly different depending on the database that you're searching, but this just gives you an overview of Embase and Medline, and they'll all be pretty similar. So this is how you search for the mesh term for cancer. So I used the link. I found that the mesh term for cancer is neoplasms. And to search for it, you type in EXP, which is short for explode, space neoplasms, which is case sensitive, with a / at the end. And that will return any studies that have been indexed with that mesh term. But then sometimes not all studies are indexed, so it's also good to search for any studies that mention cancer. Now, I only want studies that mention cancer in the title or abstract, because if it's a main focus of the paper, it should appear in the title or the abstract. I don't want a study that's been on something totally different and mentions it in the discussion. So to ensure that you're only searching the title and abstract, you can type your word *TI, AB, and that will only search for cancer in the title or the abstract. And then you can do the same for tumour. But tumour can be written in 2 different ways, depending where in the world you are. So you can use a question mark, which acts as a wild card. So this could either mean that there's no letter here, or it could be any character possible. So this will cover the 2 different spellings of tumour. And then as well, you can include that in the title or abstract. And then I want to employ my Boolean operators. So I will search for every study that's either indexed with neoplasm or mentions cancer or tumour in the title or abstract. And then I'll move on to cannabis. So search for the mesh term for cannabis. And then instead of writing cannabis, cannabinoids, cannabis sativa, they all start with the same cannab. And I can then use this star here, which is a truncator. So it will return any studies that mention cannab and then finish in any way whatsoever. So this will cover cannabis, cannabinoids, cannabis sativa, and so on. And then I want to search for marijuana, but that can also be spelt 2 ways. So that will cover both different spellings. And then I'll want to use my Boolean operators to search for cannabis, the mesh term for cannabis, or either of these 2 terms. And then I also want to search for cure in the title or abstract. And then I'll use and to make sure I'm only returning studies that mention any of the cancer operators I put in, any of the cannabis ones, and cure. So that should hopefully narrow down the number of searches that have been returned. So hopefully that makes sense.
It's actually, any comments, any question? That looks, let's see if people have any. How are we feeling? Taylor, is that a question? Okay, yeah. Taylor first. And
yeah. Sorry, it's Steph Taylor. I'm sorry, my name comes up so peculiarly. It's a quick question. Sorry, my camera's not working. It's a quick question. I was interested that you put. Can you hear me?
Yes.
Sorry, I was interested you put cure in and not treatment, because I wondered if that was a bit limiting. Because I can imagine something that is talking about the treatment with, but not doesn't mention cure either in the title or abstract, and you're missing it.
Absolutely, yeah. This is just a very, very basic overview to give you an example. This is not what a real search would look like. This is just a very, very basic kind of walkthrough to give you an idea of how you would actually carry out your real search. But yeah, in reality, you'd search for treatment, relapse-free, or remission, or other things as well. You might include cure in there, but there are definitely better terms that you could search for sure.
This is a badly designed research question, and this is my fault. Okay. All right, Hamden. You're on mute.
Oh, sorry. Just a quick question, just to clarify. The kind of the databases that you put down at the start, would you need to search each individual database, or would there be overlap, or do you have to be sure that there is no missing and you have to actually go through it all systematically?
Yes, so this slide here. So you don't need to search all of these databases because not all of them will. You just please don't.
Can you see our screen?
Oh, can you still see our screen?
Yeah.
Yeah, perfect.
Okay.
So you don't need to search all of these because all of these might not be including studies that are relevant to your exact research question. So if you just, so for example, this PsycInfo will only include psychology related studies. And if your research question has nothing to do with psychology, you don't have to search that database. So just research what these databases, what they include, and if it's potentially relevant to your research question, then you will need to search them.
So quick word, the Ovid, Medline, and Embase can be searched together, okay, in the Ovid platform. And it will mostly include health-related, medical, primary care, hospital type of articles. Web of Science have something similar as well. It's also very comprehensive. Signal would be for nursing, allied health research type studies. And then you have the Central, which is like a registry, Cochrane registry for clinical trials, ongoing or published. See what I mean? So depending, like Melissa was saying, depending on your subject, this is when you determine. But for Ovid and Medline, PsycInfo, Signal, you can search all of those in the Ovid platform together. You just need to click, and select them, and you can search all of them in one go. Okay? Any other question, anyone? Okay. Back to you.
I was just going to go through like a demonstration of how this would actually look on Medline and Embase, but I'm using Tanny's computer, so I'm not sure how smoothly this will go, but I will give it a go.
While you do that, Melissa, I think Pandey's got. Sorry, please correct me if I pronounce your name wrong. Pandey, go for it.
Yeah, it's Marika. Pandey is my surname, but that's correct. So basically, I just wanted to ask, you know how one of the requirements for a systematic review is that you need to have included every single paper that's published on your topic, right? How do you know once you've included every single paper? So like, for example, what if there are papers that you've missed? Like, how are you supposed to know that?
So you won't know for sure if you have missed anything. You've just got to have faith in your search strategy. You've just got to make it as robust as possible. Get in touch with your evidence synthesis or information specialist teams. They can help you make sure that your search is as robust as possible. But not all searches are perfect. And in a moment, Tanny will go through some supplementary searches that you can do in addition to this structured search to make sure that you do identify as many as possible. But yeah, you can't know for sure.
Exactly. That answer is absolutely correct. There is no way you can tell that someone in Nigeria has published something if it's not indexed in Medline, Embase, or all these databases we've outlined, or even if you can't access it online. I think you have to trust your protocol that you've written, that if somebody from a different part of the world follow exactly the same steps you outlined, you will find exactly the same number of articles. And when you're reading, you to get to a point that you have read about 20 articles, it looks like the theme is ABC. And you can be confident that if I find additional 5 studies, which I might have missed, the impact on the 20 will be less. You see what I mean? So you say at that point, you'll have reached what the qualitative research has called thematic saturation.
Okay.
Right?
Thank you.
Good. Okay. Should we move on with the practice?
Yeah, unless there's any more questions.
Yeah, let's do the practice.
I did the first one took ages research, so that's one I'd open. Right, so if you, this is just a search about Ovid and Medline. So if you just Google search Ovid Medline, and I click the one, the second one, it usually comes up on Google. So Ovid, welcome to Ovid. And then log in via your institution. Here we go. So this will then come up with some complete databases that Ovid includes. So you can see this list here, and it has Embase, which I'm interested in, and also Medline.
Can they see the screen?
Can you? Yeah, you can see both.
Okay.
So there are some other ones on here as well, but for my research question, I'm not interested in these. But again, research these databases to see if these might include any relevant studies to your research question. But for my example, I'm just using Medline and Embase. And it will take you to this page, which is the multi-field search. But I think the advanced search is the easiest place to go to. So if you just click on advanced search, and then hopefully you can see my search criteria here. And so I'm just going to put these search criteria into Ovid so you can see what it looks like. So to search for the mesh term for cancer, explode neoplasm. Oh, that should be neoplasms. And this one takes absolutely ages. So I did this one earlier, so you can see what it looks like when it returns the search. So you can see here the results that have been brought back from searching this mesh term, and it's 9.6 million. So of course, you can't go through the titles and abstracts of 9.6 million studies. So hopefully by the end of the study, by the end of the search, we'll have this narrowed down to a smaller, more manageable number. We'll also search for cancer in the title or abstract. And that's done twice. So if this happens, if you make a mistake, you can just click on one and remove it. And that's returned 5.3 million. And tumour has returned just under 4 million. And then you can see they've been numbered here. So that's how you can use your Boolean operators. And there we go. So we've returned 11.5 million that have either been indexed with neoplasms or mentioned cancer or tumour in the title or abstract. And that's 2 million more than what have been indexed by neoplasms alone. So that just goes to show that it's very important to make sure that you also search for your relevant key terms using title or abstract, as well as the mesh term. So then we'll move on to our cannabis terms. much less of them, which is good. Expand this so you can see the entire search. And then I wanted to use my OR operator again to combine all of these with 5, 4, 6, 4, 7. So this is looking like quite a lot. We've got 11.5 million that have a mention of cancer or index of cancer, and then 157,000 that have a mention of cannabis. And then we'll look at anything that mentions cure. And then we'll use our AND operators. So 4, which includes all of the cancer terms, and 8, which includes all of the cannabis terms, and cure. And that brings it down to 82. So you can see that by using the AND Boolean operators, it really gets rid of a lot of unnecessary studies. In reality, this number will probably be more like 6,000, anywhere from 5 to 12,000, I'd say, is normal, because you'd have many more search terms than that. Like somebody brought up with the cure keyword, you'd probably use many more keywords to identify cure. So this number would likely be a lot higher. If you're very lucky, it'll be under 1,000. If you're very unlucky, it'll probably be up to 20,000 maybe. And all of those will be your study hits. So all of those hits you'll then have to take forward into title or abstract screening that Tani will cover with you shortly. So I hope that makes sense. Does anybody have any questions?
There's a question in the chat.
Yes, so there's a question, can you add a term for age? Say if I'm interested in over 50 years. You can add a search for age, but studies may say they only looked at over 40s, or they may only looked at over 70s, for example, something like that. So if you did add that term in, you might miss many studies that are potentially relevant. So I'd probably avoid including that in the search and then just looking through your title and abstract screening to see if it's relevant that way, because you don't want to potentially exclude any studies that wouldn't be returned by saying over 50s, for example.
Absolutely. It's rare to find people including their population age in their title. Age may you may come in contact with age in the abstract, which may be relating to the average age in the results. So it can go either way. I think using age in your search would limit your search incredibly and make life even more difficult. I would limit age to when I'm starting to screen the hits at some point. Okay, is that everything with the practice? Let's go to the next phase. Yeah, I think we've described each of those databases, because that was a point I was going to come back to. I think we've done that. Can you still see my screen? Yeah, I'm just going to take it. So now that we've done the database,
you need to share your screen.
Have I stopped sharing?
I can't see your screen. I can't see your slides. Yeah, it's back.
Okay, so now that you've done the database search, what you also want to do is the supplementary search. Remember, I said earlier, somebody in Muzungu may have published a piece of paper or a thesis, PhD thesis, that is very, very relevant and is not being indexed in any of the databases that you've searched. So you want to do your supplementary search. And in your supplementary search, you're looking for great literature search, which are essentially what isn't being published in an academic journal or any commercial type piece. So you're looking at your dissertation, thesis, unpublished clinical trials. I think there are various registries where you can find unpublished clinical trials. You might be interested in clinical guidelines, etc. At Exeter University, you can often contact the librarian to give you some ideas of how to search for great literature. I think you might have the same at your university as well. So I've put a couple of places I've searched for great literature here. ProQuest, the Thesis Global. They're fairly straightforward to search. It's just you type in your title and you can come up with studies that have been, or theses that have been published in that area. You can also look at professional website, the NHS website, for instance, and I'm going to show you how to search Google for the NHS website. That's what I'm going to demonstrate now. So you can, if you Google google.uk.co.uk/advanced_search, or you click on the link and let's put the link in the chat actually. Just want to follow the steps. If you click on that link, it should take you to Google Advanced Research page. So I'm interested in cannabis and cancer. So it says here all the words as it is. You can put whatever you want, and what you want to do is to go to where it says site or domain. And because I'm interested in NHS publication on this, I can go to nhs.uk, and when you click on search, I can clearly see there it comes up with what is being published by the NHS or on the NHS website on cannabis and cancer. You can do the same for the NICE, the National Institute of Clinical Excellence guidance. So you can use the advanced search property of Google to do that. So that's the way to search for, just to recap, you can search for thesis on ProQuest dissertation or the Thesis Global website, and you can use the Google feature, advanced searching feature, to search for great literature as well. What you can also do in terms of your supplementary search is to do what we call forward citation searching, which is essentially you go into either Web of Science, Scopus, or Google Scholar, and you've identified an article title. You can put this in this databases and search for them. What the forward searching does is that it will bring up studies that have cited a particular piece of work. And the reason you'll want to look at that is, okay, it's possible that these other studies would have focused on exactly what you're looking for. So you want to search that way. The other way you can search is what we call backward citation searching, which is essentially looking at a particular article, going through the references list manually and finding what articles they cited, and those citations can actually be relevant to what you are planning to do. Again, if you're stuck, ask the librarian. Okay, do we have any questions, any comments, any observation at this stage before we move on? I think we can have like a 2-minute break in between here, but if you have any question, can we deal with that now? Okay, it looks like everyone is happy. All right, can we take another 2 minutes break? Not more than 2 minutes, so we come back just stretch your legs, get a cup of drink, and let's get back here at 10 minutes past 2. Is that okay, everyone? Thumbs up. Not you, Wawa. Fantastic. Yes. So 10 minutes past 2, we come back. Okay, welcome back. Hopefully everyone is back. So you've written a nice protocol, written your background, your research aim, etc., etc. You've conducted the search. And hopefully if your research question is as good as mine, it comes back with 82 articles, which would definitely miss all the things you need. But if your article, if your search strategy is robust enough, you might get 1,000 or more. And what you want to do is to filter through to find the articles that are relevant to your research question. And this is when the job starts to get a little bit big, you know. So the first thing you want to do is to remove the duplicates. You might want to consider whether studies published between certain period would not be relevant. So if we think about cancer, the cancer strategy was first published in the year 2000. So it might just be the case that anything before that time may be irrelevant. But actually, I might be thinking, COVID is a major event of this decade. I want to look at what has been happening since COVID. So you can limit your search, your articles by year of publication, and they're fairly straightforward to do this on PubMed and Medline, Embase, and all those databases. You can limit the same by language, by country of publication. I've never actually limited study by country of publication, but it's something you can do further down the line. Study type. So someone asking about barriers earlier. When you're looking at barriers to maybe access to healthcare, that doesn't sound like an intervention. So maybe the randomized controlled trial may not be relevant, but it's often best to just be safe and not excluding studies based on the design. You might say, well, for my piece of work, I want high quality academic journal published work alone, and I'm not interested in grey literature. You know, so you can apply that kind of eligibility exclusion to your work. Now, how do you do this manually? You know, many years ago when I was doing my PhD, I literally printed out like abstracts and titles, and I was just going through each of them. You know, not all of them, but I printed quite a few. But actually, you can use software these days to use EndNotes. You know, once you've done your search, you can export your search from Medline, Embase to EndNotes. EndNotes and Mendeley are available free via university. I think Mendeley is actually free to anyone. Anyone can set up a Mendeley account. So you can export your hits to those software where you can then be able to exclude the duplicates. You know, you can remove the duplicates at that stage. Some of the databases have restriction on how many articles you can export in one go. So I want to chunk it up by maybe export the first 100 or first 500, etc. The other thing you can use is Rayon or Covidence. Rayon and Covidence allows you to collaborate, because imagine you going through abstracts and title of 5,000 different articles. It's very difficult, and you need to be very disciplined on how you want to go about this. What I used to do is, in the early stages, it's fairly straightforward. You can remove titles that look clearly out of place and looking at barrier to access. And this one is saying gene therapy, A plus B. You know, I notice it's obviously not relevant. So I can say, well, I'm going to be doing 100 exclusion per day. You know, and if you're doing 100 per day, you can imagine how many months it's going to take you to go through 5,000 articles. It's quite difficult. So you can use Rayon. With Rayon, someone else can join you. You know, they can collaborate from wherever they are. They can access your articles from Rayon. So what you do is you have all of the articles haven't applied some of your eligibility criteria, like the year of publication and language. You've exported them to EndNote or Mendeley. You've removed the duplicates. You can then move the rest of them that don't have any duplicates into Ryan. And I think Wawa has put the link to Ryan in the chat. So once you go to Ryan, and anybody can access, anybody you've added to your collaboration can access the articles from that point on and make their exclusion. One good thing about Ryan is that you can actually, create a tab for why you've excluded what. And so when you come back to developing your Prisma or your flowchart of how you've moved from 5,000 to 2 articles, you have a well-defined reasons for doing so on the side. I think Covidence goes a step even further. Apparently, it can actually help you do some meta-analysis. I've never used this before because it's for the rich. It doesn't come for free. Ryan is free, but Covidence you have to pay. So that's the limit of our talk, is that we've not used Covidence. So maybe this is what you want to try. It goes beyond just people screening and so on and so forth. Okay. So I'm sorry, I've never used Covidence, so sorry about that. Yeah, so that's what I want to say about Ryan. Does anybody have any questions at this stage? As a matter of fact, you can actually export your hits straight away into Ryan without going through EndNote. I just find it easier. Now I've taken out my duplicate from EndNote, which may miss some duplicates still, and then move. So you just keep reducing the numbers before you get to Ryan. Go on, Ali.
No, there wasn't really a question. It was just funny because I used Ryan recently, and I was going to ask a technical question. Has you used Covidence? Is there a difference between the two and whatnot? But from my understanding, you've not used it as well.
I have not. Wawa, do you have anything to say about Covidence? Have you used it before? Do you know?
Covidence, but so I think for Covidence you can do one systematic review for free, but it has a limitation for the literatures, like how many you want to screen. And I think from the people I know who use Covidence, I think it can combine like different software from Cochrane. So maybe you can also do like data extraction or meta-analysis in the whole system, but I've never really explored it by myself.
All right. One more question, and sorry if I missed this or I'm jumping ahead because I'm sort of getting in and out of this presentation, which is a wonderful presentation. In terms of, you mentioned the database searches, which is obviously like a keystone. This might be coming later on, I'm not sure, but what do you think about, is there sort of a role for these AI tools in the search? So you've got things like connected papers and, I don't know, Research Rabbit, like, is there some way, I'm thinking in the future, because I've done a systematic review where maybe we can use them as like a hand searching if there's something we miss. I don't know, like what's your take on it? Is it, are we?
Well, I'm one of the dinosaurs in this presentation.
Okay.
So the AI, I'm just catching up. But what I understand is data mining bits that comes in when you get to screening can help. But I don't know how you do that in practice. Are you going to be typing or you copy and pasting some word from the abstract and then asking AI to look in all of these articles and find where this is being, it's it's black box, isn't it?
It is. But I was thinking, because you know how sometimes when you do the systematic reviews, they say you can hand search included papers and you see the reference list. So I'm like, in AI, you can just put that paper and then it'll draw you a map of relevance. So is that maybe a way we can use it towards the end? I don't know. I'm just sort of.
I think so. So. This book I was reading earlier, I'm going to put in the title, say something about that, about how AI can help you do your screening, because screening is a very, very difficult bit of systematic review. You have to go through title and abstract yourselves. But I haven't designed any AI algorithm, so I don't know what is going on behind my screen. And the only thing I have control of is what I've told it to do. So
no worries. I won't hijack this. I'll disappear, but just say presentation. I'm learning as well because I'm going to have to give a bit of a talk about reviews. But anyways, thank you.
Fantastic. So AI can help augment your screening process if you know how to use it. If you don't, go the old-fashioned way. Okay, so remove the duplicates. You screen the abstract and title and full text. It is critical that at least 2 people perform all of these steps, and they should do it independently. You have to be blinded to each other. This helps improve the quality of your systematic review. If you screen 5,000 articles, chances are you miss something. The other person may not miss them. So when you're going through your screening process, I think we'll suggest that you have at least 2 people doing. Now, some of you are doing your master's dissertation. You can ask your tutor or your supervisor whether or not this matters. In Exeter, we don't make it mandatory. The supervisor might look at 10% of what you're screening. This is something you have to discuss with your supervisor to determine whether or not, if you're going to publish anyway, it has to be doubly screened. Okay, so we've done all the screening. Do we have any question apart from AI question? In relation to screening, we haven't prepared to demonstrate RAIAN because it's a slightly clunky page to set it up. It's fairly straightforward if you're going to do it. Try it, it's very good. Do we have any comment, any question, or I can move on? Okay, so we've done all the search, we've screened all the articles, we've gone to the full text review, and we've identified 30 articles that are relevant to a research question. The next step that we want to do is to determine the internal and external validity of each of the articles. So there are various tools. This is the risk of bias assessment. Some people call that quality assessment. There are various tools you can use at this stage. The JBI, that is the Joanna Briggs Institute's tool for observational studies. They have one for cohort, for cross-sectional, case control, etc. You have the Newcastle Ottawa scale. I've used that one a few times and it's fairly robust way. The CASP is that critical assessment screen for, I can't quite remember. Okay, so CASP is another checklist. I've sent an article for publication and the reviewer says, well, CASP is not a risk of bias tool. And I think the reason is because CASP has got checklists. Have they done this? Have they done that? Without actually grading them, scaling them, scoring each of those bits. And that makes CASP look like a checklist rather than the risk of bias assessment tool. But I've used it in another study where it was accepted and published. There is also the Cochrane risk of bias tool. They have different tools for different study types. So you can use any of this. And what is good about all this tool is you can adapt them to suit what we're doing. Sometimes you don't have a clear intervention. Sometimes for the type of study you're doing, maybe the sample size doesn't have to be, at a certain level. So you need to look at those questions and determine how they apply to your study and make it clear in the paper how you've adapted this tool to suit your work. So that's the risk of bias assessment session, which is also very, very important steps. Again, you need at least 2 independent reviewers performing the risk of bias. They have to do it independently, blinded to each other. Sometimes there could be discrepancy or disagreement in the way they've rated a paper based on a particular criteria. You can then have a third adjudicator to look there and say, well, let's go midway, or you can go by a consensus. The important thing is at least 2 people should look at each article. Okay, we are moving very fast. Once you've done that, you've done your search, you've done your full text, you've identified your articles, you've done the risk of bias assessment. I think the usual practice is to create a table. You can have a separate table for risk of bias assessment. And I'll show you in a bit how I've done that in a previous work, just to give you an idea of how you can apply your risk of bias. But the next step is the data extraction. Now, the data extraction can come before the risk of bias. You can do it concurrently, depending on how you work in your team. But what you want to do in data extraction is to pick maybe the first 5 clearly relevant articles and read them in detail, use those 5 to develop a spreadsheet. But these are the things I'm likely to be looking for in each of these articles. So you have your spreadsheet there. An example is what we've shown on the screen. Usually you want to have the author and year of publication, and be mindful when you're citing all of this to be in series, so that whoever is reading, it makes it easy for them to access what you've done. These tables are very, very useful. Especially if someone else is doing a different study, they can just come straight to your table and look at what is relevant to them and pick ideas from there. So you want to have your author and date, you want to have your title or aim or research question. Sometimes it's good, depending on the study, to include the country of study, if this is an international type review that you're conducting. Again, it's good to put the study design. Just imagine if you pick up a systematic review on a particular subject and all you can see is, let's say, case series or case studies. You can clearly tell that this systematic review, the quality will be slightly lower than when you see a cohort study or case control study, for instance. So including the study design in that big table can be useful. Sample size, you want to break it down. If you're looking at barriers and looking across a social demographic group, you want to give us an idea of what group, the proportion in each group in your sample size. And you also want to tell us the actual sample size in that particular study. Age, gender are also useful information at this stage. And then you want to tell us the exposure that they've assessed in the study. This will be related to your PICO. This will be related to what you're looking for. And so relevant exposure, you want the relevant outcome they've assessed, and you want to give us an idea of the main findings. If you have enough space in your spreadsheet, you can create additional column for the overall global assessment for each study in terms of risk of bias. But what I've often done is to create a separate spreadsheet for risk of bias assessment. And so that's what your data extraction will look like. Just give us a snapshot of each study. Remember, you're going to have a textual description of this anyway. Again, we suggest, recommend at least 2 reviewers performing the data extraction. Okay, we're going to skip the break because we have a couple of breaks. If you have any question, either put in the chat or use the raise hand feature, you can attend to that. But I'm going to move on so that you have the rest of the afternoon to yourself. Okay, so once you have, you've performed your risk of bias assessment, you've extracted the data, you now have a good idea of what these studies look like. The next thing is to synthesize your findings. It's to bring everything together. And there are various ways of doing this. Meta-analysis or narrative review are very, very common. There's one other type of way to do this. I can't quite remember now, but these 2 are very, very popular. And I think I'm now going to pass it on to Melissa to talk briefly about meta-analysis. Do you have any question in the interim? Wow, swamps it. Comments, how are you feeling? We move too fast. I think everyone is happy.
So yeah, I'm just going to go over meta-analysis with you very, very briefly. There has been a previous masterclass that has done an introduction to meta-analysis, which was an hour and a half just for an introduction. It was a brilliant, brilliant masterclass. So if you do think you're going to need to have to do a meta-analysis, or if you do want to know more, then check out this link here. It's been uploaded to YouTube now, and they go into a lot more detail, and it's a very, very good one. I'm just going to go over the very basics so you can interpret the output of a meta-analysis and kind of just understand a little bit more what it is. So it's commonly referred to as an analysis of analyses, and it's a synthesis of quantitative data from 2 or more independent but comparable studies that have been included in a systematic review, and it just gives you a better idea of the true effect. And this table is the hierarchy of evidence pyramid. So you can see systematic reviews right at the top. Only on top of that are meta-analysis, but that is only if you do a meta-analysis when it's appropriate. It's not always appropriate to do a meta-analysis. Some examples of when a meta-analysis might not be appropriate are when you have a very heterogeneous group of studies, such as different subjects, interventions, outcomes, study designs, or clinical settings. So again, this goes back to your study selection criteria. It might be very valid to include these heterogeneous group of studies. That's absolutely fine. In that case, you'll just need to do a narrative review. There are also quantitative data that aren't able to be pulled, and this can include non-parametric data averages, such as medians or IQRs. So if you have data like this, then consider doing a narrative review, but otherwise consider doing a meta-analysis if appropriate. This is a forest plot. So this is the main kind of output from a meta-analysis. So I'm just going to talk you through what all of this is so you can kind of interpret forest plots if you come across one. So this along the left-hand side here shows the study that it's referring to. So commonly written as the first author with the data that's published. Next to it contains data on the patients that were included in each study. So this particular forest plot was taken from a systematic review looking at the efficacy of a BCG vaccine in the prevention of TB. So all of these studies each had a treatment arm, so patients that received the BCG, and a control arm, so patients that didn't receive the BCG. And then within that, who then contracted TB. So in this first study, there was 224 patients who received the BCG vaccine. 119 of them did not contract TB, but 4 did. And then in the control arm with no BCG vaccine, there was 139, 128 of those did not contract TB, but 11 did. And then the effect estimates that this meta-analysis were concerned with was the risk ratio, and this is reported as the log risk ratio with 95% confidence intervals. So the log risk ratio for this first study was minus 0.89, and that's denoted here graphically by that little red dot. And it also has the confidence intervals, which is represented here by the blue whiskers, and also the weight. And the weight of the study, if you're using a statistical package, which you probably will be, you'll need to write a line of code before you get your forest plot to just assign a weight to each of the different studies. And that's just usually a line of code. And it takes into account the number of patients within each study and then the variation of the data within each study as well. And then that provides a weight to each of your studies in your meta-analysis. And all of these added up equals 100. And the weight is represented by the size of this blue square. So you can see that the weight of this one is 5, which is small. And then the weight of this one, which is 10, and the square is a lot bigger. So you can just kind of view all of these points here and just kind of get an idea of what each study is actually showing you. All of these studies then provide an overall effect size, which is the overall output of your meta-analysis. And in this case, it's minus 0.71. And that's represented here by this green triangle and also by this red line that goes through it. So you can see how each study compares to the overall effect size. And then this black line represents no effect at all. We've also got confidence intervals here. So you can see that they don't overlap the zero effect. So that's looking as though it is significant, but they also provide you with more data down here. So there's a lot of data here. Most importantly, you want to know if it's a significant effect, which in this case it is, P is less than 0.01. But you also want to have a look at the heterogeneity, which is kind of the difference between studies that you have in your meta-analysis. And you have tau squared, and the definition of tau squared is the estimation of the variance of the true effect size. And then you also have I squared, which is a really commonly reported heterogeneity statistic, which is very easily interpretable. So it's an estimation of the proportion of variation between the effect sizes due to heterogeneity relative to the sampling variation. And if you don't understand that, or if you can't remember it, it's fine. Vittoria et al. Has produced this very easy to interpret table to make it easy to understand if there is a considerable amount of heterogeneity or not. In this meta-analysis, the heterogeneity was 92.22. And looking at this table, that means that there's considerable heterogeneity. So if you have a meta-analysis that does have considerable heterogeneity, or maybe even may represent substantial heterogeneity, you really want to explore sources of this heterogeneity. So the best way to do this is to do subgroup analyses. So for example, in this forest plot, where it's looking at the differences in patients who have had the BCG vaccine versus those who haven't, it might be worth looking back at their patients and seeing if the control arm, for example, did they receive a placebo or did they receive nothing at all? And then separating all of these studies into those who gave a placebo to the controls or those who gave nothing to the control, and then redoing the meta-analysis and having a look at the heterogeneity. And if the heterogeneity reduces, you can therefore quantify how much of that original heterogeneity was down to the fact that you just controlled for in your subgroup analysis. You can also look at whether these studies were done in different countries or the follow-up period after giving the patients the BCG vaccine. That's kind of up to you and up to your research question, and for you to critically appraise where this heterogeneity might be coming from. Another thing that you'd want to do after doing a meta-analysis is a funnel plot. So you might have seen these before, and this is just a scatter plot of the effect estimates from individual studies against a measure of each study's size or precision. So effect estimates from small studies usually scatter more widely at the bottom, and then the bigger studies kind of narrow the closer it gets to the top. And ideally, you want it to represent a symmetrical inverted funnel or a triangle. That's where it gets its name from. If it's not symmetrical, that can indicate that there is bias present. So we'll just have a look at what this could look like. So this is the graph on the previous page. This is a symmetrical plot in the absence of bias. So this is what you want to see. This means that there's no evidence of bias. These open small circles down here indicate smaller studies that aren't showing any significant effect. So in this particular funnel plot, it's looking at odds ratios. So if the odds ratio is 1, that means there's no effect. If it's below 1, then that's indicating a beneficial effect in this example. These smaller studies are showing no significant or beneficial effects really. And then the larger studies up here are narrowed closer to the true intervention odds ratio, which is around 0.4. So that's what you want to see. This one isn't symmetrical. You can see that there's loads of missing studies around here. And this is usually where the smaller studies that show no significant effect would appear on a funnel plot. So if these aren't appearing, that can indicate that publication bias is having an impact on your meta-analysis. And that's very easy to notice by the lack of studies here. And it's also pushing that odds ratio a little bit more than where the true odds ratio should probably be sitting. So it's kind of inflating the true effect. And this is another example of an asymmetrical plot. This one indicates that there may be bias due to low methodological quality of some of those smaller studies. So these open circles here are indicating small studies of inadequate quality, going through the quality assessment that Tani spoke to you about. And these are these are more biased towards larger and beneficial effects. So that's why you're kind of thinking that the bias due to the low methodological quality has been implemented here, because these 4 studies are showing a large beneficial effect. Okay, so that was a very, very, very brief and quick overview of a meta-analysis. It's meta-analysis in a nutshell, just to give you a very brief overview. Does anybody have any questions before we move on? Pass over to Tanimola.
So yes, what I was going to say is, when you're conducting a meta-analysis, it might be useful to involve someone who has done one before, so that they can guide you and they can help you to ensure what you're doing is correct. And some of these tests you're conducting, when you find potential bias, it just helps you in your interpretation, in your discussion, in your systematic review, that it is possible that the findings in the systematic review are due to bias, publication bias, or methodological quality. So let's just give you some tools to make more sense of your findings in the end. So if in doubt, ask someone who has done it, and don't do this alone. Okay, so in some cases, the studies you're pulling together are not similar, you know, because they have different outcome measures. You know, you can't do a meta-analysis for various reasons. And so narrative review might be your best option. And this is more or less like doing qualitative analysis of the data. Remember, you have your big table that gives us an idea of what each study is done and what they found, which will be useful. But then you want a textual description, like that summarizes everything, maybe thematically, or you have some nice way of bringing them together. There's this paper by Rogers et al. I think it's slightly dated in 2009, but it's fairly good paper. I've used it before, and you can see it includes different tools that you can use to narratively synthesize your work in a systematic review. It includes tabulation, which we all know, and the textual description. You know, it says grouping clusters, you know, you're just identifying different themes within, vote counting. So sometimes, well, in this study, well, you can say, well, the studies that found differences in what I'm looking for tend to be those that has large sample size. You know, say your vote counting is based on sample size. So there are various tools that I would recommend this paper if you really want to have a robust way to narratively review, synthesize your work. What I've done in the past is just to say I use Rogers et al. I remember in my PhD fiver, and the external examiner asked me the question. Well, you've only just mentioned this. You didn't tell us exactly what you did. Step by step, you explain. Oh, is it better now? So that's the paper. I would send you this slide anyway. The slide deck we're gonna share it with you, so you have access to all of this information. But it's really, really good where you don't have to use all of the tools of the paper. You can select a couple. Obviously, you're gonna have a big table. You can choose vote counting. You can choose to make sense of the odd ratios presented. You know, you have flexibility to choose what you want to use here. I think in a journal article, you may not want to go into too much detail of how you've done this, but if you're writing a thesis, you need to be clear which of these tools you employed and what you did with them. All right, otherwise you have 3 months of correcting your thesis afterwards. So we've discussed meta-analysis, and now briefly how you can narratively review or synthesize your work. There are other ways in which you can present your work, which Wawa is going to talk to us about. This is about presenting the so-called harvest plot. Go on, Wawa.
Okay, thanks, Tani. So when you have done all of the steps we talked about before, and you try, you probably include a very large number of papers in your review, and then you try to do meta-analysis, and then you found, oh, actually many of your results cannot be included in your meta-analysis forest plot, and then you try the method Tani just introduced, and then you find you make a table which probably use more than 10 pages of your manuscript. You might want to consider to visually synthesize and display your narrative result. So harvest plot is an option you can use to do this. And so you might wonder, like, what is harvest plot? So in general, you just need to categorize your result and you put them in a graph, use different features, then you vote the counting result. So I have two examples here. First, you can look at a plot in the green frame. So this example is from Cochrane Handbook. It's a very simple one. And they use the height of the bars in the plot to represent the risk of bias. So the taller bar means this study has low risk of bias, and medium means some concerns, and low bar means high risk of bias. And the shade of the bars represents different mode of cares. I put all of the notes under the plot so you can check the explanations. And so you can see there are more studies reported the black mode of cares in this review. So this is a very simple example, but you might think, oh, I actually have more results I want to display. So you can think, you can make, so in this way, you can make a super matrix, like the example on the right side on the slides. So this example is from the original paper which introduced harvest plot in detail, and I put a citation on the bottom on the slides. You can check later. So we can go through each features together, and so it's quite complicated. So first, you can see there are 4 big columns on the screen. So they represent different interventions on inequality. So it includes restrictions in workplaces, restriction in schools, restriction on sales to minors, and health warnings. And then you can see there are 3 smaller columns and under each bigger columns. So they represent the effect of the intervention. So it can be negative or no effect and positive. And then you can see there are 6 rows on the plot. So they are 6 dimensions of inequality. So it's the inequality in income, in occupation, education, gender, ethnicity, and age. So this is the general frame of the plot. Then we can look at the bars in the plot. So the taller bars in the plot means the study design is more suitable, and the lower bars means it's less suitable. Then the shade of the bar, the black means the outcome measures is hard. They use hard outcome measures, and gray means intermediate outcome measures, and the numbers on the bar means other methodological criteria. I don't actually know what do they mean, but we probably need to go back to the literature. But so in total, and we know what those features represent, but how do we understand the plot? So for example, we can see in the gender column and under the intervention of restriction in workplaces, there are lots of studies reported the result and no effect. So now, like, we kind of know more evidence is in the has like no effect on the inequality in genders by using restriction in workplaces. So hopefully this can give you a very general impression of what is harvest plot. Oh, thanks, Tani. So then I'm gonna introduce the pros and cons of this method by using this colorful plot. So this is from our study, the study from our group. So in this study, we included, I think, 47 papers reported on 6 different blood tests. So for most of the results, we cannot include them in the meta-analysis. And for the tables, I literally spent 3 days to clean the tables, but it still used like 24 pages. So I cannot like put it in my main manuscript. Then we try to use this way, and this only use 1 page. So and no result, and was like dropped from the final result from this harvest plot. And furthermore, this plot can be tailored for your study. And here you can see that so different from the last supermatrix. Here we use the rows to show the result compared with white ethnicity, and the top row means is lower than white ethnicity, and we use other ethnicity to the result result of blood test to compare with white ethnicity, and the middle means equal to white group, and the bottom means more than white group. So this provides a like very simple way to compare different studies by using a very long table, because in the table the study reported the same result might be like scattered quite apart from each other, so you can't put them together and visually compare them in a like one by one side. But I'm not saying that that table is not important. You still need to make that table, but you might have to put it in the supplementary material. Then I'm gonna talk about the cons. So as you can see, there are so many data included in this plot. It can be quite overwhelming for people to interpret the result. So you really need to think thoroughly, how do you want to design the plot rather than just put everything in. For example, here we use the height of the bar to represent the study quality. But when you are coding your code to generate this plot, you can actually code the taller bar as like low study quality, and the tall bar as the tall bar as the low study quality, and the low bar as good quality. But for people's habits, like when they are reading a plot, they tend to use tall as good and low as bad. So your table might just give your readers a misleading information. And this is just an example, so you need to think about it and think about how you put a note under your harvest plot, and to explain everything very clearly for your reader. And the last is very important thing is harvest plot cannot tell you how much of the differences. So for example, here we present the blood test, the differences in the blood test. And as you can see on the very top left, under HB, which is hemoglobin, there are lots of evidence in the less than white row. But here we don't know how much of the differences in the blood test result. So we don't know if that's like significantly like large, and if this is like applicable in the clinical practice. So this is the difference between harvest plot and forest plot. Then you probably want to ask how to make this harvest plot. So when I started, I searched on Google. There's basically nothing. And some people say you can use Excel sheet. That's the only thing. And most of the information are about horticulture. So I found lots of information about how to plant a flower or something. Then I have to start from scratch. And so basically you can think about this is just like many bar graphs, and make them into matrix, and you put different features on your bar graphs. But luckily, there's like just right after I finish all of my plots, and there's people published the R code for generating the harvest plot. I think you can adapt their code for your future systematic review if this is suitable. Yeah, that's it from me.
Yes, thank you very much, Wawa. I think the footnotes will be critical, because it looks nice and colorful. But when you have a well-defined outline footnotes to help the reader understand exactly what you mean, this harvest plot is very, very interesting because it not only includes the blood test, it tells you whether the measure of the blood test is higher in a particular ethnic group. It also gives you an idea of what the quality of the study. So in this particular case, maybe about 10 or 15 studies looked at hemoglobin, and a lot of them are relatively of high quality, etc., etc. So it's something that when you look in detail, you look closer, you actually will like this one. Okay, right. Thank you, Wawa. Thank you very much. So we're getting close to the finishing line, and this is when you want to report your findings. You've done all the hard work. You've done this synthesis either as a meta-analysis or narrative review. You want to report it in such a way that the reviewer will say, yes, publish this one immediately. This didn't quite happen in this paper I'm showing you, if you can see my screen. We had lots and lots of good feedback, which we had to work on and to get the final work. This project looked at the route to cancer diagnosis in sub-Saharan Africa. Is it too tiny for your screen? All right, make it bigger. Okay, hopefully that's better. So typically you have your abstracts, as you know, and having all of the elements. I'll just go into the main text, and you can see we have the background, and in the methods here we've you normally use the Prisma framework. It sort of tells you what to include when you're reporting your systematic review. So you might want to borrow ideas from the Prisma framework at this stage. But you can see here, we follow that same framework in this reporting. You can see we listed the dates of our search, the dates relevant to each database we searched. We list all of the databases there, and we have a table showing all of the search terms used. As you can see here, we have our population, exposure, and outcome. We've listed all of them there clearly for any very, very detailed reviewer to have a look. And anyone anywhere can use the same search terms, and you can actually help people doing research in this area. So they can just go to your paper and do exactly what you've done. So that is the search terms, and here we list, we make it really clear that we search request thesis for grey literature. I think we found none in these places, and then some people would like to list their inclusion and exclusion criteria as bullet points. One of my co-authors didn't like bullet points, so he preferred narrative or textual description this way. So it's entirely up to you and your team, but you have to be clear exactly what you've done. It's clear on English. We focused on population. We excluded studies that that is not within the so-called sub-Saharan Africa. I think we have a definition, a WHO definition for what we mean by sub-Saharan Africa. So all those things need to be clear. So this selection, against our own advice today, only one person did the screening here, but we have to be honest that this was only one person that did it here, and that's the limitation of this study. And you can see how we outlined what we've done in the data extraction and synthesis. Exactly what we've done, and you can see here I cited the Rogers et al. Paper, that was what we followed, but not actually detailing exactly what we've done. For your case, you might want to say 1 or 2 words on what you've done there, just in case someone is interested. And quality, risk of bias, we use the Joanna Briggs and the Newcastle Ottawa scale. I think I need to show you that table of quality. Let me just show you that one quickly. So this is what we did. So we can see here what we've done here is just for each of the questions in the Newcastle Ottawa scale, we've listed them here. I think in a previous study, we stated whether we changed the questions or not. And I think in this case, we haven't changed any of the questions. We've just applied the questions the way they are in the tool. So you can see that some of the questions comes with 1 star, you award 1 star if they meet the criteria, and sometimes 2 stars. And we can see how we listed every study and how they met each of the quality criteria in the Newcastle Ottawa scale. Again, so there is a separate Newcastle Ottawa scale for cohorts study, for cross-sectional study, and we use the Joanna Briggs risk of bias too for qualitative type study. You can see for qualitative type study, what we have is whether they met the criteria or not. Yes or no is what, so it's more or less yes or no. But it may not be perfect. What is important is transparency, it's clarity of what you've done, and that's what we've shown in this study. So, and then you have your textual description of initially describing the number of studies you found and telling us how 5,083 articles ended up in with you reviewing only 18. When I'm reviewing papers, I always check these numbers with my calculator. If they don't add up, I just say that in the report or in my feedback to you that the numbers don't add up. So that can be quite embarrassing. Check your numbers and make sure they add up, basically. And we really, to give us a flavor of where the studies were published, because this study is looking at a whole region, we had to be clear that how many studies were published in different parts of the regions, and that does give you a flavor of whether this study is actually representative of the region you're talking about. Okay, and then we have the massive table that Wawa I don't like, which is showing the study characteristics. You can imagine it's taking long to actually open. So it's 18 studies. If you're not particularly interested in this type of work, it might be time consuming to go through each of them. This is where your harvest plots can be powerful, so to speak. And then, so once you have all that and you have all the table, you then have a textual description, step by step of the 18 studies. It has to be interactive. I can easily follow what you've done from 18. 7 did this was what they found. As simple as you can, and then describe your risk of bias. We know you have the table which shows what risk is associated with each paper, but you want to give us a global picture textually in your paper. And then you discuss your main outcome, how they relate to what you've done, and then the rest, as they say, is history. Okay. Just to flag the Prisma statement, which is like a guide to help you in your reporting. The flow chart I showed earlier, Prisma has a template that you can use, just fill in the numbers. You can expand it or adapt it to suit your work, as the case may be. But I think that is all we've got. Well, publish once you've done all that. Let's see if we have any comments or question, and then we can wrap up. You can come online now or show yourself camera, turn the camera up, and any questions, any comments.
I have a question, but it's not for this part. It's for an earlier part. Is that okay, or is it?
Yes, yes, anywhere.
All right. So our number one, you were mentioning a brief bit about what do you want to call it? About checklists, and that some of them they don't have cutoff scores, so maybe you don't consider them as a checklist. What are your thoughts on using a checklist and then creating your own cutoff score? So it might be that you feel a check, especially when it comes to like qualitative work, you might find a checklist which really like it fits what you do well, but they haven't given a cutoff score. So you sort of decide either to look at a previous paper that made up a cutoff score or arbitrarily use one. Like, what are your thoughts on this?
So for qualitative piece of work is qualitative.
Mm-hmm.
Let's use tools that say yes or no, met or met, because you really can scale them per se. I think the problem you're going to meet is a reviewer will ask you, have you piloted, have you trialed this tool? There are lots and lots of tools available that you can pick ideas from. So what in some of the study, what we've done is we actually change the scales.
Okay.
You know, so for my work, the way each study would have measured ethnicity matters. The way they defined ethnicity in their study. So I'm going to allocate more weight to that question in my tool as against what they've done in that tool, regardless of what the tool looks like. I'm going to adapt it to suit me. So that you can do, because you know this tool has been piloted before, whereas yours hasn't been. Some people create theirs. It just means that I'm going to be reading that bit in detail, and sometimes you forget to include all the detail you need in the paper of how you've developed this fancy risk assessment tool that nobody's used before. If you haven't put enough detail, I'm just going to come back to you and say, well, you've used a tool that we don't know anything about. Can you tell us more about it? And somebody might just reject the paper based on that.
Yeah. That's really interesting point. So you, as you mentioned, it is okay, for example, if there's a justification to put a more heavy weighing on one part because it suits that topic or okay.
Yes, cool. And you say that because this part in question is critical, we appointed so weights to it.
Okay, cool, thank you.
Good. You said that's not your name, Taylor. Can you?
Sorry, my camera's not working. It's Steph. Don't worry.
Steph, okay.
It's just that I can't change the name that pops up. Sorry, I don't know how to do that. I was just thinking that I wondered what you thought. I usually would say to somebody who's starting systematic reviewing, and at the beginning you talked very helpfully about looking to check if there was another review in your area. And then you said, if there is another review in your area, it doesn't necessarily mean that you shouldn't do the review, because you need to scrutinize that review and see if it's really addressing the question. And I was just going to push you a bit further and say, what do you think about, I would suggest that somebody actually critically appraise that systematic review using one of the tools like Amstar or RAmstar or other tools, and that would also teach them about a review, critically appraise one that they may do, and you know, sort of win-win all round.
Absolutely, but this entirely depends on how much funding you've got to do this extra bit of work, and if you've got the time as well. But that would be the way, to do it. The ideal way to do it is to use Amstar, to use all those other tools that you can use to review systematic reviews, and then when you summarize that, it will give you a good justification for actually doing a new one. So that's a very good point, Steph. Thank you very much. Well,
thank you.
I hope. Oh, there's a message. Okay, let's look at the message quickly. Dissemination refers to publishing your results. Okay, communicating the results, patient clinician. Yes. Oh, yes. Thank you. I think that's correct. What we mean by dissemination is how you publish. Sometimes you want to you present at conferences, etc., etc. Any of those bits are part of your dissemination. You want to do that as well. You want people to, including putting it on Twitter, you want people to know about your work. Of course, you're not going to put the entire paper on Twitter. You might have like a tweet pic that you design and then put your link, the link to your paper there. So yes, that's what we mean. Hopefully we've been able to give you a flavor of what a systematic review entails, including how you synthesize paper, what you do in terms of researching, and what to do in terms of reporting. We haven't given you too many prescription apart from the fact that you need to have at least 2 reviewers at different stages, and they have to be blinded. We, strongly encourage you to do meta-analysis when the studies are suitable for it, because a reviewer will look at it and say, you should have done a meta-analysis, and they will come back to you, so to advise you to do it. Forest plot is a brilliant way to present your findings in a way that is easier to access than the big table. On this note, do you have final words, Melissa?
No, nothing from me.
Wawa, final words?
Me neither.
Okay, I want to say a very big thank you to you all for attending this masterclass. Thank you to SPCR for hosting us. Please do email us if you have any question. Thank you so much. Have a wonderful weekend.
Thank you. Thank you for that. Have a lovely weekend.
Thank you.
Thank you, everyone.